Thank you. So we developed the HyperCVAD in 1992. In 2006, because of the data that was emerging, we switched to a pediatric-inspired regimen, which was led by Dr. Mike Ritting, a pediatrician. In 2012, we found that the data were identical with HyperCVAD and the pediatric-inspired regimen. So we went back to the HyperCVAD because you can use the HyperCVAD across all age groups with those adjustments, while the pediatric-inspired regimens, you start getting in a lot of trouble beyond the age of 40. And the second important thing is with the HyperCVAD, you can add many of the targeted therapies safely, and I'll show you that in our development. So what I'd like to emphasize is the reality today is that both these models are outdated. We have used for 6 decades the intensive chemotherapy over 3 years. It was a success story in pediatric ALL where 80% of the children are cured on protocols, not so in the community practice and not so in the poorer communities where the cure rate falls down below 50%. Those intensive regimens, whether HyperCVAD or pediatric-inspired, give you a potential cure rate of 50% with a lot of toxicities. So we need to move on. So what should we do? I think in Philadelphia-positive ALL, I'll show you that at MD Anderson, we're not using anymore the intensive chemotherapy, and we're using ponatinib with blinatumomab with some caveats. In the pre-BALL, we started adding the CD19 and 22 antibodies, and I'll show you why I think our implementation is better than the sequential studies. So really, the devil is in the details. And we're using the MRD with the clonoSEQ to monitor the patients and to change therapy if they have very little disease. And finally, we are using the CAR T cells as a consolidation rather than inactive disease. So I'm going to show you first the Philadelphia-positive ALL. So in 2000, there was the first inflection point where we started adding the BCR-ABL kinase inhibitors. And this is the historical background against which we were working, where the cure rate in Philadelphia-positive ALL was 35%, even when the transplant is applied. So the second inflection point was in 2017 when we found that blinatumomab was superior to chemotherapy. And here I show the rationale for the 3 changes we made. The first change was changing to ponatinib because 3/4 of the relapses were with the T315I mutation, and that's shown on the left side. In the middle was the change to blinatumomab from intensive chemotherapy because it was equivalent to intensive chemotherapy. And then as the patients were living longer, they started having CNS relapses, so we increased the intrathecals from 8 to 12 and more recently to 15. So this is the current Philadelphia-positive ALL regimen, ponatinib 30 milligrams daily, blinatumomab starting with the induction when the white cell count goes low, 5 courses of blinatumomab, ponatinib goes down to 15 milligrams in molecular remission, and it goes for about 5 years, and I'll show you why. And this is the data that we just updated. So in contrast to the historical data, now you can induce almost everyone in a complete remission. What you see is we use the transplant very sparingly in 2 out of the 76 patients. And for the first time, we have a 4-year survival, which is close to 90%, which we've never had before. But we are seeing relapses, mostly in the patients with a high white cell count over the age of 70,000. And this is shown on the slide. So we think that the patients with an initial white cell count over 70,000 are at a high risk for CNS and systemic relapse. So we're going to introduce CAR T cells there or 1 course of methotrexate high-dose Ara-C. Other people have done the same. So you saw at the ASH meeting the sequential ponatinib blinatumomab from Italy. So there are 2 modifications. They still use the ponatinib at 45 milligrams daily in the younger patients. And the last bullet shows you that they have to reduce the dose in 40% of the patients because of side effects. But similar to what we have done, they are using now the transplant in a small number of patients, about 10%, and they report a 1.5-year survival of 95%. So I summarize, as of today, the 4 non-chemotherapy regimens. Ours is the second column. There's the dasatinib, blinatumomab in the third column, published in the New England Journal of Medicine. And then the last column on the right side is the trial from Italy. So what you see is, I believe that our study has hit the right spot, starting the blinatumomab during the induction and using a lower dose of ponatinib, and we have an estimated 4-year survival close to 90%. Now, people complain that you have to use the TKIs indefinitely. We just published this in Cancer, showing that you can stop the ponatinib, but provided you have documented an NGS MRD negativity for about 4 to 5 years. So similar to the CML data, and the patients are not relapsing, and I show on this on the slide on the right side. So the modification that we've done is very simple. We added in yellow 1 or 2 courses of high-dose methotrexate in remission in the patients with a high white cell count, and I think this will take care of both the CNS and systemic relapses, and we're using 15 intrathecals. Now, moving to the B-cell ALL, this is where the therapeutic revolution comes in the form of the antibodies targeting CD19 and 22, and also the CAR T cells that we're using now in remission rather than in active disease. So everybody knows the randomized trials of blinatumomab or inotuzumab versus intensive chemotherapy, which showed that those 2 antibodies were equivalent or slightly superior to the intensive chemotherapy. But when you use them in the FDA-approved dose as a single agent, you do not benefit much from the cure rate, and you're using a lot of money for that. So we immediately moved to the younger patients, where we did 3 modifications. We reduced the HyperCVAD to 4 courses from 8. We added the blinatumomab in 4 cycles in sequence, and we shrank the pump maintenance to about 15 months with more blinatumomab. Later on, we added the inotuzumab. Now, in contrast to the DeAngelo study, where there was a lot of mortality, and I warned that cooperative group at the start of the study that they were using inotuzumab at a high dose, which is going to cause problems, and nobody believed me, so the results did show that there were problems. What we do is use the inotuzumab in a fractionated dose, 0.3 milligrams per meter square, day 2 and day 8 for 4 times, so a total of 2.4 to 2.7 per meter square, rather than the 1.8 per meter square repeated twice, which was used in many of the other studies. And this is the data that we already published, and we have now about 100 patients. On the left side, you see for the first time a 4-year survival of over 80%. This is not only in the patients who are MRD negative. I'll show you the trick in the LISO trial. It's only half of the patients who end up on the study. So there's 50% of the patients who receive 3 cycles of chemotherapy, and then they are kicked out of the study. So the benefit with the 5-year survival of 85% applies to half of the denominator. In this study, it's the whole denominator. In the middle, I show the red curve where inotuzumab was added. And on the right side is the comparison to the historical data with the HyperCVAD of atumovimab. And we're not the only people who have done this. There's plenty of data from Europe in single-arm trials that shows the same early data compared to historical data, which looks very positive. Now, here I showed the LITSO study, and this is a very important one because it led to the FDA approval of the drug for acute lymphocytic leukemia. So now we can use blinatumomab in all settings, whether the patients have MRD positive disease or MRD negative disease. But look at the design of the trial. It starts with 488 patients. They receive 3 courses of chemotherapy. and you end up with only 46% of the patients who are randomized. So when you look at the curve in blue, and this is a pediatric-inspired regimen, presumably, half of the patients, a 5-year survival of about 60%. That's not including the other half of the patients who may have done worse. The 85% applies to the addition of blinatumomab, but only to half of the patients who became MRD negative. Now, we use blinatumomab also in MRD-positive disease because we know in the right bottom curve in adult ALL that if you're MRD positive, your 4-year survival is 20%. At MD Anderson, we use in such patients the blinatumomab for 5 cycles, and I show here the improvement in the 4-year survival from 20% to 60%. On the right side, I show that allogeneic transplant added does not improve the results because of the mortality. So this is where the CAR T cells would be very useful. In the older patients, so this is 60 and older, I doubt that many people use the pediatric-inspired regimens. People use the intensive chemotherapy. But the results of the intensive chemotherapy, whether pediatric-inspired or otherwise, leads to about a 3-year survival of 10 to 15%. So that's terrible. We cannot keep doing the same thing and wondering why it doesn't work. So we did something similar here to what we did in the younger patients. We used the mini CVD for 4 courses. We added the inotuzumab and the blinatumomab in sequence, and we doubled the 5-year survival rate to 50%, which is shown here. And we did this also with a matching analysis. And here I show on the left side the SEER data. So if you're still using the intensive chemotherapy, pediatric-inspired or otherwise, you see the SEER data, a 5-year survival of 10 to 15%. On the right side is the MD Anderson data, where since 2010, we switched to the mini CVD in Oblina, and we more than doubled the survival. And again, this is done in many other centers, low-intensity therapy to which people added either inotuzumab or blinatumomab, and all of them are showing better results compared to the historical data. Now, in T-cell ALL, we do not have yet targeted therapies, although the CD7 CAR T cells are coming. So this is where we had the opportunity to explore nelarabine, because nelarabine is a good drug, but it was outcrowded of the B-cell ALL because of the effective antibodies. And what I show here in the serial studies that we've done, on the right side is the addition of venetoclax has improved the 4-year survival to close to 75% or more. So I think venetoclax is a very good drug, and we're going to continue exploring it in T-cell ALL. In ALL relapse in the adult, in contrast to childhood ALL, if you relapse with ALL in adults, it's a death sentence. And this is shown in 1,000 patients from 2 different countries where even though you can get them in remission, and even though you transplant them, the potential cure rate is less than 10%. We use the same mini CVD in Oblina regimen, and in 125 patients, we show that we can induce a marrow CR in 85% of the patients, and now the 5-year survival has jumped to 40%. In the middle is the use of the 2 antibodies in red, so a better survival, and in the last figure on the right side is transplant, yes, no, so no benefit from transplant. So this is where the CAR T cells would be useful. I'm going to show you 2 more pieces of information which again are going to revolutionize the treatment of ALL. The first one is the subcutaneous blinatumomab, which we can use at 5 times the higher dose than the IV blinatumomab with similar toxicities. I showed the data published in the American Journal of Hematology in the first 27 patients. Refractory relapse, almost all of them achieve a remission, but the importance is the median survival. So remember, with the IV blinatumomab, the median survival was 7 to 8 months. Here it's 14 months. So I think it is a more effective drug, and we're going to incorporate it into all our frontline and salvage combination studies. And the last thing is what I refer to as the dose-dense mini CVD in Oblina. So instead of using blinatumomab in sequence, what we do now is 6 courses of mini-CVD. We add the inotuzumab, the blue arrows, in the first 4 cycles for a maximum of 2.4 milligrams per meter square. And now the blina does not start in sequence. It starts on day 5 of every course for about 18 to 20 days for 6 cycles. I'm showing the very preliminary data, but now we have more than 22 patients with similar data. And these are patients with refractory relapse ALL. The overall response rate, everybody achieved the remission. But notice the NGS MRD negativity. So after 1 or 2 courses, we cannot see the disease in 1 million cells, which we've never seen in the past. And the early data shows a 1.5-year survival of over 80%. On the right side, I showed the HyperCVAD inotuzumab in red, the in the salvage setting, the mini-CVD inotuzumab in red, the mini-CVD blinatumomab in blue, and then the dose-dense mini-CVD in green. I really think intensifying the targeted therapy upfront is going to lead to much better results. Thank you for your attention, and I'm happy to debate further.